Welcome to this webinar that I will note from the very beginning is being recorded for posterity. This webinar brought to you by Stop TB Canada, by Partners in Health Canada, PIH, and Médecins Sans Frontières, Doctors Without Borders, aka MSF. I'm Adam Houston, your moderator. I'm here wearing two hats, both as medical policy and advocacy advisor for MSF Canada, and as a member of the Stop TB Canada Steering Committee. And it feels like a bit of an auspicious time to be talking about DRTB. This is some to add rifampicin-resistant TB. At all, that's a really positive step. I'm joined by speakers coming to us spanning 3 continents and 9 time zones. And we're here to talk about diagnostics, a topic that has often failed to garner the spotlight it deserves. You're likely used to organizations like us talking about access to medicines. Indeed, in the Canadian context, Stop TB Canada and MSF Canada are both concerned with the fact that many DRTB medicines, like delaminid, pretomanid, bedaquiline, many of the older drugs, aren't actually registered in Canada. But of course, in order for patients to receive the right treatment, first they need to be properly diagnosed. And diagnostic technology has improved in recent years, including diagnostics for use in low-resource environments. But unfortunately, affordable global access to those diagnostics hasn't caught up. So, as my snazzy T-shirt here suggests, we're going to be talking about the Time for Five campaign, which is an effort by a coalition of over 150 organizations and allies to bring down the price of the widely used GeneXpert cartridges. We're going to hear from clinicians with experience with TB and other conditions requiring diagnosis, both in Canada and elsewhere in the world. And we'll hear about Canada's commitments around supporting the global TB response and the need to ensure that new tools are affordable and accessible wherever they're needed. But just before we get there, and as people continue to join, a little bit of housekeeping. First, thank you very much to the speakers. Thank you also to Results Canada, who has been masterminding these Stop TB Canada webinars and blazed this trail a bit in Canada. And also to Eduardo and the MSF Access Comms team who are taking care of the technical bits behind the scenes. I'd also like to give a special shout out to the TB fighters, some of whom are planning to attend today and who've been really great in spreading the word about the Time for Five campaign. Second, if you're involved with TB in Canada, whether you're a healthcare worker, a researcher, a TB survivor, whatever capacity, and you're not currently connected with Stop TB Canada, please do come check us out, join the network, connect with people, even just find out when the next of these webinars is going to be. Third, very important, please do sign the Time for Five petition if you haven't already done so. It will appear in the chat at some point during this presentation. I know yesterday we were on the cusp of 100,000 signatures. I'm not sure if we've broken that already or if your signature could be the one to tip us over the edge. And lastly, before I get off the stage, at least metaphorically speaking, we're going to hold questions until the end after all the speakers. So please save up those questions. Looking at the people who've already joined, I see a wealth of expertise from Canada and around the world, which is really great to see. So thank you to all of you for tuning in, and we hope to hear from you and draw on your expertise at the end as well. Now, without further ado, or further Adam, as the case may be, let's go to our first speaker. Live from Berlin, Ruhrhof, campaign manager at MSF Access Campaign. So in a career spent centering communities and advocacy to build resilient movement for systems change, Saloni has worked in a range of positions with state and nonprofit actors, including state governments in India, the German International Development Agency, GIZ, Open Society Foundations, and others. And she's currently leading the Time for Five campaign coalition, and it must be said has really driven a lot of its successes so far. So Saloni, over to you.
Thank you very much, Adam, for that wonderful introduction. I'm happy to start right away with my presentation. So just bear a minute with me till I share my screen, and we're good to go. All right. If you can see my screen. Great. Okay. So welcome, everyone. Thank you for joining. And thank you, everyone, for this opportunity to also amplify Time for Five campaign here in Canada with a Canadian perspective. So I'm here to talk a little bit about this lovely blue box, as you can see, the GeneXpert tests and how we are advocating for its affordability together with this coalition that Adam mentioned about. A quick introduction. If I believe most of you in this call, you know about the GeneXpert. So GeneXpert is a fully automated platform that can run these blue boxes cartridges for testing many infectious diseases, including tuberculosis, HIV, hepatitis, STIs, among others. And this is run by a company called Cepheid. So these are the makers of this test, which came into being in the late 1990s. And it's important a little bit when we talk about the campaign already to know a little who we are targeting. What are these companies about? And it's not just one company. It's Cepheid, yes, the manufacturer of the test, but also its parent corporation called Danaher, which is a large American global conglomerate. It's essentially a financial investment corporation, which has about 25 different operating companies under its umbrella in 4 segments of biotech, life science, diagnostics, and environmental. They are ranked 130th on the Fortune 500. The CEOs, millionaires, the owners, billionaires. They rank 108th in the world billionaire list. So very prominent. They take a lot of money from these tests, and just like fun fact to mention here that they invest that in movie making, in Wes Anderson movies, and also just got an Oscar this year for that. So we're talking about big, large companies here who have up to 32 billion revenues per year. So this is just a snapshot of the companies to mention why we are targeting them and what is coming, you will see in the next slides. First, to mention why Time for Five. Why is it important really in low and middle income countries? So we are particularly focusing about access and affordability of the cartridge in these countries where there is high disease burden and some countries have limited resources. So one is, of course, there are global TB testing gaps. Only 38% of the notified cases were tested with the rapid molecular diagnostics as initial test. Less than 50% of all RIF-resistant patients were tested for fluoroquinolone resistance, and particularly for children. It's super, super important because less than 60% of children with TB are not even diagnosed. So PEDS TB, pediatric, is especially something that's missing the focus. And that's, again, you can see similar patterns, parallels in HIV testing gaps as well. Only 50% of all HIV-exposed infants are tested for HIV within the first 2 months, like as recommended by WHO for testing. Up to 50% of HIV-infected children will just die without timely diagnosis and treatment. So this, as we know, the WHO recommends the point-of-care diagnosis test, like GeneXpert, that it's used for all children because there are not other alternatives that we have. So the testing gap for diseases, it goes on also for hepatitis. It's multifactorial, many reasons, but the cost of diagnostics is essentially a key factor. And Cepheid is the top supplier, both to national governments as well as to humanitarian missions globally. I mean, they have an effective monopoly over this. So that's key to note. What's also very interesting is that Cepheid received public investments for research and development for innovating GeneXpert technology, about $252 million, which comes both as state funding as well as philanthropic funding. As you can see, it's a snapshot of how where the funding has been coming from. And after that, this is the narrative, the campaign narrative that we are taking, that this is just double dipping, first getting state funding for R&D and then charging more and profiteering from the wallets of the poor. So this is, as I mentioned, essentially the crux of the Time for Five campaign, which is founded on a very solid evidence that MSF built in 2019, where we commissioned an independent analysis to really assess the cost of production of this GeneXpert cartridge. And the results of that, it can be found. The link is here. We'll share the slides with you later. It's a deep analysis. You're welcome to see it. The findings of it are basically that it costs Cepheid only about between $3 and $4.50 to produce each cartridge, but they charge, based on their tiered pricing model, up to $20 for the different cartridges that you can see in that bar graph on your right. And this is essentially preventing governments from scaling up testing and for disease elimination. And we think with bringing the price down to our target price, which is $5, we can meet these gaps. Why are we calling for $5? Because as per our study, with $5, Cepheid still makes a generous profit. So these are all costs that have been modeled into the study. And it's also good to note that this study was done in 2019. After that, we've had COVID, and the volumes of GeneXpert have multiplied many fold. So after that, I think now the production cost has gone down way further. It costs much less than $3 and $4.50, and so the profit margin is even more right now. This is now just a snapshot to show how we have been going on with the campaign. The campaign is essentially not new. We have been advocating for this since 2019, but the first phase of real campaign escalation that came after, like, post-COVID, and that was in September 2023 last year, in the lead up to the United Nations high-level meeting on tuberculosis, where you can see the pictures reflect. We were busy doing a lot of different diverse campaign actions. The one in the middle, many of you maybe who are here today in this call who were there, especially Robin, which was the first time I met Robin here, which was excellent. So we were activists, people from Stop TB, from Global Fund Advocates Network, TAG, PIH, everyone all together. You can also see our very dedicated, committed supporter, John Green, who's an author, philanthropist, and a dedicated TB activist now, who gave our campaign a push. And because of that, I think we have really been able to bring out and simplify the whole narratives around testing and diagnostics, made it simpler, brought it into the public sphere, and we've been able to achieve some modest successes. So this basically is just a snapshot to reflect what we achieved. On 19th September 2023, we had our first win in record time. This was like after 10 years of negotiating with the company and absolutely unfruitfully, this was the first time that we had an announcement from Cepheid in a really record time. So target turnaround in 6 days, and they got super nervous. It was PR crisis for them, reputation at stake, and they announced that, okay, we dropped the price of the GeneXpert MTB RIF Ultra cartridge, which is the basic TB test, by 20%. So they brought down the cost from approximately $10 to $8, which alone is having a huge impact, which you will see cost-wise what it means in the next slides. But besides this, an additional win was also that Danaher committed that they are going to sell this cartridge at cost, and they are very willing to go through an audit, which will be done by an independent, internationally accredited agency, and we will assess the price of this cartridge. So this is still to be implemented. We are waiting for the execution. No news on that, but this was the very, very big win. What it means in terms of financial savings, what implications it has. So just as you can see on your right-hand side, the column of the price of different cartridges, here we have reduced the price only of one cartridge by 20%, $2. And that saves the Global Fund $32 million annually, with which we can afford 3.6 million additional tests for countries. Now, what's going on currently in the campaign? So we are in the phases where we are not just resorting to public pressure, but we are also working with our very diverse range of stakeholders. So we're working on policy with our stakeholders like the Global Fund, with Stop TB, etc., but also with countries. So with national TB programs, national HIV and hepatitis elimination programs, where countries are standing up for the rights of their patients and writing to Danaher and Cepheid, basically just enunciating the field realities, what difficulties they have, what are the gaps, what are the problems. And a snapshot of these letters can be seen here, that we have now country letters from 8 countries, as well as from the Americas TB Coalition, which has been a real good force. And some of them with such enthusiasm on really pitching in for this campaign, that when we approached, for example, Ghana, to the first country with the first national AIDS program to sign a letter on the price reduction of GeneXpert, they signed it within 24 hours, which is, usually a process which is very bureaucratic. It takes months to coordinate this. And as we have also seen the exemplary role of these NTPs in the past campaigns, with the Johnson & Johnson campaign, for example, which was also led by MSF last year, which was very crucial for the price reduction of bedaquiline and for the secondary patents. Now here, just to mention how can Canada step up, or donor countries. So not just top down, where we are talking about national programs of countries, but also as donor countries investing in international multilateral partnerships, financial partnerships. How can they play leadership role in global health equity, both for funding as well as for governance? And this is, we think that as one of the largest donors, Canada can distinctly, it has the capacity to leverage influence on multilateral financing partnerships like the Global Fund, and pave way, be a leader in establishing accountability mechanisms which kind of gauge what are the investments that we are making in TB tools, which essentially also compose as public goods, as I mentioned, because they are financed, their innovation is financed from public money. So this should definitely kind of ensure that all funding is meeting the access requirements in LMICs and not funding just the wallets of, these global conglomerates. Now, second is to increase transparency about these investments in procurement of goods, as well as in the cost of goods assessment of the TB tools, which essentially we are talking about diagnostics here. So this is twofold. Why? Because countries are paying twice, as I mentioned, first by financing the R&D, and second by continuing to pay inflated prices for diagnostics. So this can be settled if we have increased transparency, one, in cost of goods assessment of the diagnostics funded with public investments, and second, in the procurement of goods. So like we do have, it's imperative to get audits for country spending when we have grant mechanisms. Why not have that also from the industry and from international financial institutions? The third one is to ensure also civil society oversight in these accountability mechanisms, which as well as in value for money audits. So which, of course, transparency, accountability, civil society oversight, we're talking about these keywords, which are the core values in many policy frameworks of the institutions we work with. But how are they really operationalized, and how true do they stand to very open participation of civil society? That is something we feel that needs to be improved, because so far, for example, we have not heard anything on the audit, and this is to ensure that Cepheid is not doing an independent audit of its own good. It has to be transparent. There has to be a public report, which also sets the tone for rigor and sets precedent for other competitors and future suppliers. So this is one area where we also feel that donor countries can have considerable influence on the board of Global Fund, and the last one is then all of this also leads to maximizing the impact of our investments, which leads me to the comparison of resource mobilization versus resource optimization, because we are constantly talking about bringing in more money, but also how through these COGS audit or value for money audits, how do we press on the savings and use those savings for reallocation of funds for essential diagnostics and meet those testing gaps. So this is the role of donor countries, where we see that there is scope to work together. And lastly, besides other actions that are upcoming, where we'll keep you posted through our listserv, through our email list, we currently are running a petition to amplify our campaign. This morning, as Adam mentioned, thanks for breaking my surprise, Adam, we collected 100,000 signatures, so which is a big feat. Within 2 months, from 176 countries, we're running the petition in 8 languages, and we're not stopping. So if you haven't signed the petition yet, I encourage you to please sign it. I'll share the link also in the chat, and that's from me. If there are any questions, happy to take them.
All right. Great. Thank you very much, Saloni. We'll be taking some questions at the end. I am now going to attempt something, simultaneously introducing the speakers while also loading their slides, which I hope is within my capacities. But very happy to introduce our next speaker. It's actually a double act, not only a double act, but a spousal double act. Normally based in Saskatoon, but coming to us from Lesotho, where they're working with partners in health at the Botshabelo MDR TB Hospital in Maseru. So first we have Dr. Molly Brindamore, a general pediatrician whose work is focused on underserved children and marginalized populations, including as a co-founder of the REACH Clinic, providing team-based care to refugee children, as the first pediatrician at Sanctum 1.5, a supportive home for mothers and infants at risk or living with HIV, and serving Northern First Nations as a TB consultant for the Saskatchewan TB Prevention and Control Program. She's also my colleague on the Stop TB Canada Steering Committee. She's joined by Dr. Ryan Miley, a family physician who has practiced in rural and northern Saskatchewan, inner city Saskatoon, and rural Mozambique. He currently works as a TB consultant in the Athabasca region of northern Saskatchewan and at the Westside Community Clinic. He's also a recovering politician, having served until recently as a member of the Legislative Assembly for Saskatoon-Meewasin and leader of the official opposition in Saskatchewan. He's also written 2 books that I will cheerfully plug on health in Canada, authored with UBC Press. Those are A Healthy Society, How a Focus on Health Can Revive Canadian Democracy, and A Healthy Future, Lessons from the Front Lines of a Crisis. Spoiler, that crisis is COVID-19. So I'm just going to share their slides here. Hopefully I will do that correctly.
All right, looking good. Thank you very much, Adam. Greatly appreciate the chance to speak with you tonight. We're talking to you from Maseru, the capital of Lesotho, where we've been for the last 6 months working with Partners in Health. Today, I'm going to talk a little bit about the work that we have been involved in here, the work that Partners in Health does here around MDR-TB in particular, and then make the connections between that larger team effort and where diagnostics fit in, and how important it is that that this campaign be successful and we see the prices drop. Adam, you can go on to the next slide. So right here, you're looking at my clinic on Monday this week. I was out in the mountains near Tabatseka, speaking to this Buti young man who lives 40 kilometers from the health center where we were supposed to see him. So he'd been up since 5 in the morning coming by horseback. Because he's done his active treatment, we decided to meet him partway and do our exam and follow-up by the side of the road. He's accompanied here by, you can see his treatment supporter, hired by PH to accompany him from the beginning of his care for MDR-TB all the way to the end. So this treatment supporter has been going to this patient's house every day, twice a day for 6 months to make sure that he's able to successfully take his medications. Next slide, please.
And so this Abuti is a young man. Abuti means young man in Sesotho, a little brother. And he's got lots of things to do. He's busy herding cattle, far in the mountains, and it hasn't always been easy to get him into clinic. But harder yet, he has a 1-year-old son at home who's had symptoms. And we've had a very hard time getting the boy into the clinic due to distances, complications with communication, difficult transportation. And those are only the beginning of the challenges in finding cases of pediatric TB. Adam, you can go to the next slide. So as you can see from there and from other pictures that we will have throughout this talk, Lesotho is a beautiful country. It's stunning, but it's also a hard place, especially when it comes to TB. The incidence of TB in Lesotho is 661 per 100,000. So it's the highest per capita rate of TB in the world. It goes through major challenges in diagnosis, in treatment. It has a TB HIV co-infection rate of more than 50% and a high burden of MDR-TB, so of multi-drug resistant TB, about 4% among new cases and double that among previously treated cases are resistant to our usual treatment for TB. Now, 63% of all TB cases are never found or treated. That's data for Lesotho. And In pediatrics, these numbers are not known because we don't have much data in peds, but they're much, much lower. It's estimated that less than 10% of TB cases in peds are found. And of those who are found, that's both in adult and peds, 37% start treatment, and only 29%, so about 3/4 of those who start are cured. And the case fatality rate for TB in Lesotho is 26%.
Next slide, please, Adam. So the care of multi-drug resistant TB is challenging. And for patients like Abuti, it takes a team. The team that we're working with in Lesotho is supported by Boston-based global health NGO Partners in Health. And I see that we're joined today by Mark Brender, the Executive Director of PIH Canada. In Lesotho, PIH has three main activities: the Rural Initiative, establishing primary care in remote communities; health system strengthening, accompanying the ministry in developing the five S's of staff, stuff, space, systems, and social support. And the third piece is the delivery of MDR-TB care in Lesotho in partnership with the Ministry of Health. Next slide, please. If you're familiar with PIH, you're certainly familiar with co-founder Dr. Paul Farmer, an inspiring leader and actor in global health who sadly passed away in 2021. One of the things he was well known for was advocating for the benefits of medical science, the latest technologies being available to everyone, especially the patients who need it the most, the patients who are the sickest and the poorest. Next slide, please.
So the first step to diagnosis of TB and MDR-TB in particular is diagnosis. So here on this slide, we see Ntate Retabile in the lab in Botshabelo. And if you can go to the next slide, Adam, we will see the entire hospital lab team, and they use GeneXpert PCR to diagnose TB, but also which drugs it's resistant to. So we base our diagnosis of MDR on the GeneXpert, but they also do many other key lab findings, the CD4 counts, the viral loads, approximately these 3/4 of MDR-TB patients who are also living with HIV. So here we can see the extremely dynamic and effective team at the Botshabelo MDR-TB hospital lab, where samples from across the country are processed. But they also support rural sites and their mini labs, which allows them to process basic but life-saving labs, such as CBC, simple chemistry, and in most cases, a GeneXpert machine that allows for TB bacteriological confirmation within a couple hours. Go to the next slide.
Now, some of those patients who are diagnosed are sick enough when they're diagnosed or later on in their treatment that they need to be admitted to the Botshabelo MDR-TB hospital, a specialized hospital in the capital in Maseru, where they're cared for by a team of nurses, ward attendants, x-ray techs, mental health counselors, cleaners, administrative and logistical leaders, as well as a medical team of general practitioners, internists, a critical care specialist, pediatrician, until very recently, and I saw him on the call, Dr. Prithvi Prasad, our thorough, meticulous, and inspiring infectious disease specialist, who hopefully will find a new ID specialist soon. And we also recently added a radiologist to the team, which is making a huge difference. Next slide, please. Most of the patients we see in and out of hospital are adults, like May Selewani, here being examined by Dr. Ninza, a critical care specialist from Zambia. May Selewani, who has agreed for us to share her story, spent months in the hospital away from her family and her 3-year-old daughter so that she could recover from complications of DRTB treatment and meningitis. Next slide, please.
We do sometimes have children in the hospital, but they are rare. For example, our friend Tlotla here, whose mom also agreed for us to share his story, came with us from one of the mountain communities far away in Mohotlong to get worked up and have his treatment started in hospital. There's very few patients in the MDR-TB program, and Tlotla is a rare exception. It's not because MDR-TB somehow spares kids, to the contrary, but TB in kids is so hard to diagnose, both drug sensitive and MDR. And often the testing that we have is not adequate for them. So the majority of TB cases in children, more so of MDR-TB, are not diagnosed and these kids are missed and often die without a cause having been identified. We can go to the next slide. Where we see here the team looking after patients in the ICU, which has been recently founded in PIH just over a year ago, and where the team provides a level of care that fits with the philosophy of PIH, the belief that everyone deserves to benefit from scientific advances. So PIH promotes the notion of a preferential option for the poor in its medical services, believing that people shouldn't be denied good care because they live in poverty, and that those most in need deserve the most help. We can go to the next slide. And here, another member of the team, Tate Tuso, and the pharmacy team prepare the medications, including a highly specialized MDR-TB drugs for the inpatients, but also for the bulk of the MDR patients who are seen in the community. Next slide, please. And then here we see the team loaded up and ready to go. The community team who's ready to head out to the district health centers, and they will travel between 2 hours and 6+ hours to reach the patients, sometimes continuing their travels for several hours so that the patients only have 1 night of travel on foot to do instead of 2. Undergoing a treatment that involves taking medications daily for 6 to 18 months is not easy. The illness itself, medication side effects, and the near constant of underlying poverty and food insecurity make it even harder. So that explains why as few as 80%, although 80% is a good number of MDR-TB patients successfully finish their treatment. We can go to the next slide.
And so as you see, it takes a team from the treatment supporters to the specialist care in the ICU. MDR-TB is challenging to treat, and it takes a lot of folks chipping in. And the work here in Lesotho reminds us a lot of our TB work in Saskatchewan's north. And I saw Tina Campbell and Dr. Ibrahim Khan on the call who know this situation well. More snow, no mountains, but remote communities, a persistent problem with poverty and tuberculosis, and the need for a team-based approach, as we see here with our traveling crew of Nurse Leanne, Medical Office Assistant Marvi, and X-ray Tech Scarlett. It means there's a lot that Canada and Lesotho can learn from each other in the fight against TB. Next slide, please.
And in Saskatchewan, we've seen recent extreme increase in TB cases in Saskatoon, in particular among people living with HIV. And so we know that we're best be ready to learn and act quickly. So we can go to the next slide. And so to successfully reduce or eliminate TB in Lesotho, in Canada, or anywhere else, we need to be expanding our active case finding work. So PIH Lesotho is piloting an exciting new TB Hunter app that uses underground screening combined with AI chest X-ray reading to identify potential cases. And this is follow-up with PCR testing. And that allows to not only track in real time the number of cases that are diagnosed, but also who gets treated, who finishes treatment, who had a positive chest X-ray, who had a positive GeneXpert, etc. And we can go to the next slide.
Which brings us to what we're talking about today. Today's campaign. Lowering the price of GeneXpert will make a huge difference in our ability to find and treat cases of TB wherever they are. It's worth remembering, however, that these tests aren't flawless. We have to be willing to treat based on clinical diagnosis, not just bacteriological confirmation. And because even under ideal conditions, in study protocols, in adults who are properly supervised for good quality sputum production and more than one sample submitted, PCR testing still misses cases. In children and people living with HIV, in places where collection of sputum is done in remote locations, and when there's not enough money to collect and process multiple samples, these aren't ideal conditions. It's the real world, and that sensitivity plummets accordingly. Non-official data of sputum collected in all the rural sites in Lesotho shows a less than 10% positivity with GeneXpert, much less than what we should be expecting based on incidence and published sensitivities. That said, GeneXpert bacteriological confirmation helps us to be sure, helps us to convince funders we're using money wisely and treating responsibly, and it allows us to find cases of MDR-TB that would otherwise go unidentified. Having less expensive testing would allow us to repeat samples, would allow us to use rapid diagnostic methods more often for non-sputum samples, and it would lower the threshold to allow us to be more proactive in who we choose to test. And that would allow us to increase our testing positivity to get closer to what's expected based on the incidence of TB in the population. We could also see us moving beyond GeneXpert for TB and using it more in other conditions. For example, HPV here in Lesotho, where we have high rates of cervical cancer, or syphilis in Saskatchewan, which has been absolutely going through the roof. Next slide, please. But perhaps more importantly than expanding testing is, as we reduce those costs for testing, we can also reduce the costs in a health system that's already overburdened and underfunded, and in a country where one of the biggest things that our patients need is food. Like you see Abuti and his treatment supporter loading up the donkey to take the maize meal and other staples back home to help support him during his treatment. In countries where that's the kind of help people need, there are far more important places to spend that money than on increasing the profits of Cepheid. So with that, we'll again thank you for the chance to participate in today's discussion, and pass the mic back to you, Adam.
All right, great. Thank you for that. I do see a hand up, so just a reminder that time permitting, we'll take questions at the end here. I will stop sharing that, and I will introduce our final speaker, coming to us all the way from Ottawa, Dr. Robin Waite, who currently works as an independent consultant, focusing efforts on applying community building, project management, research, and advocacy skills to the fight to end TB. She's currently working with the TB Alliance to project manage and support the Fast Track the Cure initiative. She's also my colleague on the Stop TB steering committee, and if I can editorialize in someone else's biography, really deserves a ton of credit for her core role in revitalizing Stop TB Canada, while in her previous role as Director of Policy and Advocacy with Results Canada. So Robin, over to you.
Thanks so much for the introduction, Adam. I am just going to get my slides up on screen. Can we see them? Yes. Yeah?
Yes.
I haven't seen thumbs up. My computer's just being strange. One sec. Okay. All right. So my name's Robin, everyone. I am a global citizen who gives a shit. I'm a champion for not-for-profit and civic space. And as Adam mentioned, I'm an independent consultant working in global health. And I take my self-identification of a global citizen who gives a shit really seriously. So in addition to working as a consultant, I'm actually in the process of soft launching a passion project called the Global Sentinels Movement, which is essentially a movement of global citizens who give a shit, working together to secure social and climate justice, good governance, health equity, and economic security for all. And my role here today, as per our superstar moderator, Adam, is to really put in context today's conversation against Canada's international commitments to end tuberculosis and what they're currently doing in the fight and what they could potentially be doing more on. And I'd like to build on some of the points that Saloni mentioned in her presentation. And then also, I think part of my role here is to inspire and equip you with some additional information for how you can support the Time for 5 campaign, in addition to signing the petition here in Canada, and to model some advocacy and action so that you can walk away with new ideas for how you can make an impact. So let's tuck in. How is Canada currently showing up in the fight to end tuberculosis? Well, I'm actually really proud to say that Canada does fight for what counts on a global stage. So top right of this slide, you can see me campaigning and fighting for what counts in 2022 asking the Canadian government to invest $1.2 billion in the Global Fund to fight AIDS, tuberculosis, and malaria, which is doing critical life-saving work to end these epidemics. Despite people telling us that our ask of 1.2 billion was crazy and never going to be achievable, and that 30% of an increase on our last investment was too much, I'm really proud to say that Justin Trudeau and the government of Canada stepped up at the 7th Global Fund Replenishment Conference and invested $1.2 billion in the Global Fund. That's a picture of me at the bottom, giving him an appreciation kiss during that conference. But this is important in the TB response because the Global Fund is the largest international financer of TB programs around the world. And as such, they play a really important role in procuring tools like the GeneXpert that we're talking about today. So Canada is also investing smart-ish in the TB response. I say ish because we could, of course, be doing better, and we'll get to that later. But I say smart because we're not just investing in the Global Fund, we're looking at a comprehensive approach around what it takes to end TB. So we're investing in the likes of FIND, which is the Foundation for Innovative New Diagnostics. They essentially invest as a not-for-profit product developer in developing new diagnostic tools and getting them to those who need them. And while FIND did not develop the GeneXpert, they did work to do independent evaluations of the tool, and they are supporting implementation in priority countries. So we're not investing in TB diagnostics with FIND, but because we invest in FIND, there's an opportunity to do so and do more in the future. We also invest in TB Reach, which is a granting mechanism with the Stop TB partnership, which is essentially all about pilot testing new innovative approaches to finding people with tuberculosis and getting them on the treatment that they need. So they played a role early in the days of GeneXpert coming out to pilot test the new tool and then provide the evidence to support its scale up. And Canada is the leading and foundational donor in this mechanism. So while I'm proud of Canada, I'm also hoping that they're really thinking about the Time for 5 campaign right now, because it is certainly time for 5. And the Global Fund can demonstrate this to us as well right now. So that $1.2 billion that we raised in 2022, the Global Fund is now working alongside countries to develop new financing plans and work plans for how to use those dollars to save lives and end the epidemics. And what we're seeing in that process, which is called Grant Cycle 7, is that despite some recent reductions in the cost of TB commodities, there are massive funding gaps still. And that's especially true in TB linked to diagnostics. And this is a slide from a Global Fund board meeting, by the way. And if we look at this specifically in a country context, let's look at Nigeria, for example. This Global Fund slide again is showing that the estimated gap for buying cartridges, these basic TB commodities for diagnostics, is $29.8 million at the moment. And for a country like Nigeria, that has made massive progress in the last few years in terms of finding people and diagnosing people with tuberculosis, not having access to those resources to sustain this momentum would be absolutely devastating and an absolute shame. So I don't think it's a coincidence that you're seeing this big growth, doubling of diagnosing people with TB in Nigeria, and the fact that Nigeria was the top country to use resources that became available through the Global Fund to mitigate against the impact of the COVID-19 pandemic. So new resources came out, Nigeria used those resources in a smart way, purchased things like the GeneXpert cartridges, and went out there and they found more people with TB and got them on the life-saving treatment that they needed. So what happens if these funding and cartridge gaps aren't filled then? Well, that historic progress that we're seeing in Nigeria could be at risk, and the plans that they have in place to sustain that momentum could be lost and not funded. The ambition and the readiness to deploy resources for quality TB program that we're seeing might not come to fruition. We could see a slowing down of the adoption of these promising new tools that we know are critical to rapidly accelerating progress towards TB elimination targets that are woefully off track, by the way. We also pass up the chance to leverage the TB response and strengthen the TB response to advance equitable pandemic preparedness. And we set up the outcome of the 2023 high-level meeting on TB to be a failure, simply because we've set targets that we're not willing to finance. And if I were to talk to colleagues at Global Affairs Canada, I would also tell them that their investments are at risk and they're not being fully realized. So how could Canada do more to support equitable access to TB tools? First, they can invest more. There's massive financing gaps in the global TB response. And not just that, massive gaps in financing required to invest appropriately in TB R&D across diagnostics, drugs, and vaccines. And Canada's not doing its fair share right now in that space. We could also invest better. So rather than putting public resources towards for-profit, commercially interested entities like Cepheid, who are not demonstrating to be good actors, we could put resources into not-for-profit product development partnerships like Find, who don't have a commercial interest and are well-positioned and are navigating and disrupting the market. We should also continue to do our learning. There's so much we can learn from the PDP model to date, from the for-profit pharma model to date, from the COVID-19 experience, and we should be gathering that information, distilling it, and coming up with ideas for how to improve equitable access in practice. And I'm not going to read these all out to you, but I did read those resources and more to come up with some potential ways forward for Canada to consider. And I will just read out a few of them now. And it's not just about investing better, though. It's about leveraging their positions of influence, as Saloni said. So where they sit on a board, their position of influence as a donor, and where they're showing up in the international policy setting forums. So one thing Canada could do is make funding contingent on equitable access principles, as well as make that a core to their reporting to donors and make those reports publicly available. And just to say that there's already a recommendation coming from the Standing Committee on Foreign Affairs and International Development for Canada to do just that. In a 2022 report, a recommendation said that Canada should ensure that its agreements to provide R&D include clauses that allow intellectual property resulting from that funding to be easily licensed to manufacturers serving low and middle income countries. They, of course, should be prioritizing transparency across the value chain, and as well as working to discern and communicate what best practices for equitable access look like in practice anyways. And lastly, they could be funding and creating the policy environment for a more truly end-to-end model for research, development, and manufacturing of essential products, thereby limiting the need to dance the dance with for-profit partners who sometimes undermine equitable access. And just to show that one of the PDP's, Cepheid, has indicated through their journey and is communicating publicly the challenges they're facing and making good on their equitable access mandate because they're having to dance this dance with for-profit partners and striking balances. So Canada could be doing more on this front, and there's again a recommendation already for them to do so, coming from a 2018 report of the Standing Committee on Health, where a recommendation was put forth for the Government of Canada to explore the feasibility of the public manufacturing of generic medicines. That's public manufacturing of generic medicines. So that's all for me. Just to end with a yes, we can end TB. Yes, we should all support the Time for 5 campaign. Thanks for reminding me I had a t-shirt, Adam, and threw it on. But remember, it's not just the governments that need to do this. The fight depends on you. You can lend your support, you can lend your pressure, you can sign petitions, you can understand how Canada is currently operating and push them to continue to do more and better. And that's all for me.
All right. Thank you very much, Robin. It's usually very embarrassing when we show up wearing the same thing, but I think Time for 5 shirts, we can make an exception to that. We do have a couple minutes for questions, so I hope we can get to those. Eduardo, I hope we've made the technical things to allow people to ask. I think maybe the best thing would be to I see 3 hands right now. Maybe let's take those questions and hopefully those can be kind of concise questions, and then we can answer them all together if we can try that. So I guess first, Adam Deng, you've had your hand up for quite a while. And let us know in the chat if we haven't yet switched over to Alawi.
Yeah, I'm happy. Hello.
You can sort of hear you. It's not a great connection.
Hello.
All right.
I had a network problem here. Since you were conversing, there's a network problem. I'm in South Sudan, and as well as you know, South Sudan is one of the 4 countries where my everything is very poor. So that's why it's very difficult to assess everything. And you know, it is very good to be in this meeting about tuberculosis because South Sudan here is one of the major countries that is affected by tuberculosis. And we are looking for a fund, a global fund, in order to fund the South Sudan in terms of tuberculosis. Because as well as we have a vulnerable group like women in South Sudan, they are very vulnerable. The major cause of mortality.
Adap, I'm sorry, it's quite hard to hear your question. We do want to get to it, but would you be able to type it in the chat? Because again, we're going to answer these all 3 questions just to make sure we that everybody has heard it. If you could just type it in the chat, please. Thank you. Daphne, I think you were next. And good to see you, Daphne.
Hi, good afternoon. Good to see you all. I don't have a question, but I do have a suggestion. When we sitting in the steering committee with Stop TB Canada, I would just love to keep suggesting to reach out to smaller indigenous communities. I can literally say, like, we're almost as living in 3rd world, like Nigeria. I would just love to suggest to you all who might have to seek funding to stop TB in Canada, to work harder to translate these small presentations that will be given to the public so that it could reach out to small communities. Might create a huge pandemic because small communities receive out of community members who come and work as such as teachers, police, construction workers, and they might contract the TB here in small communities, go back to their city life and spread it all over. I think that would be one of my main suggestions. I would love to see to translate into indigenous into English and French as well, of course, and any other foreign language that might be useful for those who come to Canada to move here. That's my suggestion.
All right. Thank you, Daphne. And I think unless any of the speakers have to run away, I hope we can Stain, let's just get to your question as well. And good to have you here, Stain.
Yeah, thank you. Do you hear me, Adam? Because you hear me? Okay, cool.
Yes.
So first of all, congratulations with the webinar, and I mean, I really enjoyed it. Super exciting presentations. I do have 2 questions actually for Mali and Ryan. First, I want to congratulate you for your work in Lesotho with PIH, with the team, and the work you're doing for the people with TB in the country. One of the 2 questions is, if you could expand a bit on the situation outside PIH project, like how is the situation in Lesotho in terms of the fight against TB, and also is MOH? I mean, I assume they are largely or almost exclusively dependent on global funds money. How you can envision like the impact of a price reduction of expert cartridges like for TB? What would be the impact for a country like Lesotho on a global scale? I mean, on the national scale, not only in the PIH clinic, which we can be very similar to MSF, but also very, I mean, I'm much interested on the national situation actually for TB in Lesotho, and what the impact could be of a fair price for GeneXpert.
So a couple quick thoughts. One, that as we mentioned, we're getting a very low percentage of the cases that are out there actually identified and on treatment, and that availability of a cheaper test could make a big difference. It also does that bleeds into, for lack of a better term, into the MDR TB world as well, because when the cartridges are difficult to afford or unavailable, there was a period earlier this year where there just weren't any in the country, so our hospital was empty. Now that they're back, our hospital is filling up. Not that we want to see our hospital fill up, but we know that the patients are out there if they're not with us. We also know that sometimes you get diversion of GeneXpert because they are expensive, and so there's a profit to be made. So reducing the profit that's to be made from them because they're cheaper and more available would also mean that it's less likely for you to see things diverted out of ministries through corruption, and be able to again see our dollars going more directly to patient care.
Of course. Thank you, Ryan. And one other question for either for you or for Mali. I don't know who is the pediatric TB doctor, but I mean, it's super difficult, as you say, to diagnose TB in children. WHO has updated their guidelines. In MSF, we have a large project now to implement the WHO recommendations for pediatric TB, including the treatment decision algorithms. And I'm wondering, in the app you showed, whether the intensified WHO recommendation the algorithm is about the treatment decision algorithms, the AMB with or without access to X-ray. If you're implementing the algorithm, and if if MOH is also adopting that, I mean, these updated guidelines, which can save lives in children in their national policies, if you could expand a bit on that.
Yeah, that's a super interesting question. Actually, we were just talking about that with the PIH executive director this morning on how do we convince the workers on the ground to follow the guidelines, because Lesotho has updated its drug-sensitive TB guidelines in 2023, and they included that new recommendation from WHO for the clinical diagnosis of TB with the algorithm. With or without chest X-ray. So it's allowed by the national guidelines to diagnose TB like this. On the ground, there's still a lot of education to be done, both at the level of the diagnosticians who are seeing patients, but also of the coordinators of the TB programs who are still on the thinking train that a diagnosis of TB should be bacteriologically confirmed. Yeah. So it's very difficult to convince people to start, kids in particular, on treatment without a positive GeneXpert. And as we know, so the positivity of GeneXpert in kids is very, very low.
Yeah, absolutely. Thank you, Mali. And I agree, it's one thing to have it in the national policy, but it's another thing to implement it, right? And to get the doctors trained to actually implement it. Thank you, and congratulations with all the work you're doing. Adam, do we have 1 minute? I have one question for Robin as well, or actually one suggestion. Except that there are other people.
I won't cut you off.
Okay, Robin, thanks a lot for also for the work and the exciting overview of what Canada can do in terms of improving access to life-saving tools. I have one suggestion on your slide where you have the different points what Canada can do, and I think the audit, and as Saloni explained, one of the wins of the Time for 5 campaign in September was the price reduction. But secondly, is the first time I have seen a diagnostics company committing to do an audit and to prove their cost of production. We are following that very closely, of course, because it's a unique opportunity and it should be done, but it should also be done in the right way. And Saloni explained it very well. It should be transparent. We are afraid that won't be transparent, right? And also the Global Fund is probably not much interested to make it fully transparent. And one suggestion or one thing to reflect, and maybe we can take it offline after the webinar, is also from the Canadian perspective. As an investor in the Global Fund, I assume countries want value for their money, right? So I think Global Fund could take a much stronger position in getting the audit done in the right way, meaning transparent, and that countries shouldn't buy blindly, because we fear that at the end of the audit process, we will get a number. We have no idea how they come up with that number. So of course we can talk with the Global Fund, but I think also the big donor countries to the Global Fund can also request value for their money, because if they understand that actually the majority of their investments in GeneXpert through the Global Fund goes actually to the pockets of Danaher, I assume they don't want to see that. So I think we can take it offline maybe, or feel free to share already some thoughts, but I think it's a unique opportunity also for changing that narrative that we shouldn't follow, the companies blindly. And the last point, Robin, Global Fund has double standards, right? Because they are auditing the countries all the time, the governments, what they do with the Global Fund money, right? And we can see it online. It's on the web page. You can see every single report. And apparently for commercial entities, it's not the same. They don't want to really make sure this audit is happening in the correct way and is transparent. So I think there's much to do also on that side to improve transparency in the diagnostics market. I will stop.
I agree. And if it's okay, I'd just like to respond really quickly with some potential actions that we can take away offline following this discussion. Would be like, we didn't speak to each other as speakers ahead of this session, right? We all developed our slides and then saw each other's slides at the session. So now we've started the conversation around, okay, how can we bring the different threads of work and understandings together to do something about it? Maybe something we could do is get together with Stop TB Canada and the Time for 5 campaign, get together a briefing for Global Affairs Canada. They are very receptive to hearing from us about what we think they need to know before board meetings, or how they should show up in their role as a board member to the Global Fund and others. So perhaps that's one takeaway. Like, let's get together a briefing session with Global Affairs Canada so that they can be leveraging that position of influence better.
Wonderful. Yeah, happy to help and to support them.
All right.
Great.
In fact, Stain's making me wake up super early to have one of those meetings this week on Ottawa time. I'm on the West Coast. Thank you very much, first of all, to our speakers. Secondly, thanks very much for everyone who's joined us. P.S. Sign the petition if you haven't already. And, a reminder, Stop TB Canada does do regular webinars. Please do check that out, particularly if you've enjoyed this. So thank you again to everybody, and I believe, don't quote me, but we should have a recording of this, for people who might have missed it. Thanks again. Thanks for staying a few minutes late, and hope to see you all again.